Good afternoon, and thank you for joining Brooks Pierce's July 2021 webinar on OSHA's new Emergency Temporary Standard, or ETS, for the healthcare industry. 18 months into a pandemic, employers in the United States continue to grapple with a constantly shifting landscape of health and legal guidance from federal, state, local governments and agencies. In this webinar, Claire O'Brien and I at Brooks Pierce will delve into the specifics of compliance with ETS, addressing issues such as how to conduct a hazard assessment, OSHA's expectations for employee and employer notification, and record keeping and reporting requirements. This presentation will be most useful for non-exempt employers whose employees provide healthcare services or healthcare support services through this ETS. However, this ETS could be a harbinger for a later rule, more broadly applicable to more work sites. We hope to field your questions, which you may pose using the chat feature at the bottom of your screen. Due to time restrictions, we may not get to those questions until the end, but please do post them in the chat feature as they come up. Also at the end, we will display the code that will enable participants to obtain professional development credit from SHRM. And these slides will be emailed to you later and also available with the video of this presentation on our website, likely tomorrow. As stated, I'm DJ O'Brien, and my practice is in litigation and labor employment more generally. Claire O'Brien, our co-presenter, no relation, is a professional in the healthcare industry advising companies on a wide range of compliance issues. You'll have our contact information, and we certainly welcome the opportunity to connect with you after this webinar. Importantly, the content of this webinar and our remarks are not to be considered specific legal advice. They're for general informational purposes only. We certainly hope that you find them useful, but particular situations may require you to consult with your legal counsel. And we, in fact, would be happy to confer directly with you and your colleagues and to provide legal advice. Also, please be aware that as we speak to you today on July 28th, 2021, that the rule that we are going to delve into is subject to change. OSHA itself has specifically said, as if they had to, that it is subject to change. And as we know, 18 months into a pandemic, and with this rule issued late in a pandemic, we are still grappling with a lot of changes in work sites and the accompanying regulations. With that, I'll turn it over to Claire to speak to the overview of the new ETS.
Thank you, DJ, and thank you all for being here today. I'm Claire, and I'll jump right in with an overview of the new standard to get us started. The Emergency Temporary Standard mandates the development and implementation of a COVID-19 plan in workplaces where employees provide healthcare services and healthcare support services, and requires compliance with a series of related requirements intended to protect those healthcare workers most likely to have contact with someone infected with the virus. You may be wondering why now? Why has OSHA issued this standard so late in the pandemic? And the answer is that this timing was not the original plan. The president issued an executive order in late January, stating that the federal government needed to act quickly to reduce the risk of workers contracting COVID-19 in the workplace. And that order required OSHA to consider whether COVID-19 emergency temporary standards were necessary and to issue those standards by March 15th of this year. Obviously, that didn't happen, and Department of Labor Secretary Walsh attributed the long delay just to the evolving nature of the pandemic. And he also noted that he himself was not sworn in until March 23rd. Interestingly, there has already been some pushback against the narrowness of the standard. Several labor unions have filed lawsuits arguing that the standard fails to protect employees outside the healthcare industry who face similar grave danger from occupational exposure to COVID. For example, workers in the meatpacking industry, grocery stores, transportation, correctional institutions, etc. Who must comply with the standard? With certain exceptions, the standard applies to employers whose employees provide healthcare services or healthcare support services, including hospitals, nursing homes, assisted living facilities, home healthcare workers, emergency responders, and ambulatory care settings where suspected or confirmed coronavirus patients are treated. Healthcare support services are those services that facilitate the provision of healthcare services. For example, employees working in patient intake or admission, food services, medical laundry services, medical waste services, or medical equipment cleaning and reprocessing services. This is a non-exhaustive list, but should give you a general idea of who needs to comply with the standard. Of course, employees who are not subject to the healthcare ETS should still refer to OSHA's general COVID-19 guidance. And employers in states with their own occupational safety and health plans may be subject to different requirements under those plans. So make sure you look not only at the standards from OSHA, but also any state requirements. OSHA has specified certain exceptions to the standard, so categories where the standard does not apply. And these include, as you can see on the screen, first aid performed by an employee who is not a licensed healthcare provider, the dispensing of prescriptions by pharmacists in retail settings, non-hospital ambulatory care settings where all non-employees are screened before entry and people with suspected or confirmed COVID-19 are not permitted to enter the settings. So here you could think of a physician's office or a specialty clinic or a medical imaging center. Also accepted are well-defined hospital ambulatory care settings and home health care settings where all employees are fully vaccinated and non-employees are screened before entry and those with suspected or confirmed COVID-19 are not allowed to enter. And the list goes on. Healthcare support services not performed in a healthcare setting. So for example, off-site laundry or off-site medical billing, employers who have that kind of work site would not be included in the standard. Similarly, telehealth services performed outside of a setting where direct patient care occurs would not be covered by the new standard. And note that for healthcare settings embedded in non-healthcare settings, the standard would only apply to the embedded healthcare setting, not the rest of the physical location. So OSHA has given as an example a clinic in a manufacturing facility. The new standard would apply to the clinic, but not to the rest of the manufacturing facility. What does compliance entail? The new standard imposes requirements in several compliance areas. OSHA has described the COVID-19 plan as the basic requirement and the main requirement of the standard. But the standard also sets out rules for patient screening and management, physical distancing, physical barriers, cleaning and disinfection, vaccination, training, anti-retaliation, and others that you can see here on the screen. And today, DJ and I are going to talk about the ones that are bolded. We're not going to hit all of these just due to time constraints, but we are going to delve into the details of the categories that are bolded here on the screen. Probably the most important consideration from your perspective is the compliance timeline. So the standard became effective immediately upon its publication in the Federal Register on June 21st of this year. And compliance with most provisions of the standard was required within 14 days, which was July 5th. And compliance with provisions related to physical barriers, ventilation, and training was required by July 21st. But there are still some things to consider. If you wish to submit written comments on the emergency temporary standard, OSHA is accepting those comments until August 20th. So you do still have time. And now DJ is going to take us into some compliance specifics.
Right. We hope that if you're covered and not accepted, that you're in compliance with this, but this is an opportunity to review those specifics. So we're going to try to cover some of the specifics of what is required, starting first with a COVID-19 plan. Covered employers, must develop and implement a COVID-19 plan for their workplace. Now, if it's more than 10 employees at your work site, this must be in written format. We think the best policy, though, would be to have a written policy in case you need something to point to, but it appears to be required in written form only for those employers who have more than 10 employees. Importantly, there must be a designated workplace safety coordinator. This person must be knowledgeable in infection control principles and practices. And importantly, this person persons must have the authority to implement every aspect of the plan and to monitor and ensure compliance with the plan. There must be a workplace specific hazard assessment. We're going to get into the details about that. This process of developing a plan must involve non-managerial employees in the hazard assessment and in the COVID-19 plan development and implementation. This could take a couple different forms: safety meetings, a committee, conversations between supervisors and non-managerial employees, and other similarly interactive processes. Those of you who have responsibility for dealing with ADA issues and disability requests to have an accommodation may be familiar with that. And the interactive process in that context is designed to be just that, interactive, not take on specific words, but to actually delve into the specific situation. And so it can take on many different forms. It could even involve, possibly not as a minimum, but involve employee surveys or a suggestion box. The plan must include policies and procedures to minimize the risk of transmission of COVID-19 to employees. That's the purpose of this. Importantly, it should document those policies, even if not required to be in writing, but also the procedures that the employer has used to comply with the requirements in each of the required compliance areas. And it's not just put in a plan and then you're in place. You must monitor each workplace to ensure that the ongoing effectiveness of the COVID-19 plan is there, and then update it as needed. So at the outset, of course, is the hazard assessment. Again, there's flexibility that's at least contemplated by the ETS. This process is intended to help employers identify and understand where the COVID-19 hazards may exist and what can be done and controls can be put in place and implemented to minimize transmission risk. There's flexibility to determine the best approach to accomplish the hazard assessment, but there is a floor. Flexibility does not mean carte blanche. At a minimum, the assessment must include an evaluation of employees' potential workplace exposure, and that's for all people present at the workplace. So in the healthcare setting, patients, coworkers, employees from other entities and vendors, members of the public, all of those people who potentially enter your facility or at the work site must be considered as possible potential exposure to your employees. There must be identification of places and times where people actually come into contact with each other in a short distance or otherwise in poor ventilation, for example, and where there's a risk of COVID-19 spread. So that includes considering how and where employees and other persons who are affected enter, leave, and travel through the workplace in consideration of potentially hazardous sites at the work office. Employers must assess each employee's potential COVID-19 exposure, but can do so generally. If you have similarly situated employees who have similar daily experiences, you may not have that individualized assessment necessary. You may be able to more generally assess the risk. The hazard assessment has got to document the information about the specific hazards that are identified. Come up with a plan to abate the risk in a timely manner, the date the assessment was performed, the names and titles of the individuals who participated in that assessment, and then the subsequent written plan, description of actions to be taken, communication of that plan to the workforce, a list of actions to be completed by employees who may be affected and the dates by which they may actually be completed. And then, of course, again, written documentation of what you've done to comply with this ETS. OSHA has provided a hazard analysis template. It's readily accessible on the OSHA website by searching for the ETS. And that's not a bad place to start because it's what OSHA itself is putting out there.
I'm going to talk a little bit now about cleaning and disinfection. The new standard sets out requirements. Many of you have likely already been employing these or similar practices for some time now, but the standard requires employers to follow CDC guidelines for cleaning and disinfection of services and equipment in patient care areas, resident rooms, and for medical devices and equipment. OSHA has incorporated by reference specific editions of CDC's COVID-19 infection prevention and control recommendations and CDC's guidelines for environmental infection control, as well as EPA's List N for cleaning agents. And OSHA requires hospital-grade disinfectants to be used in those areas. In all other areas, employers should make sure that high-touch surfaces and equipment are cleaned once a day and should provide alcohol-based hand rub that is at least 60% alcohol or provide readily accessible hand washing facilities. Screening, employers must limit and monitor points of entry to settings where direct patient care is provided and must screen and triage patients, clients, and other non-employees who enter the setting. OSHA views asking questions about COVID-19 symptoms and illnesses as the minimum requirement for screening, but screening could also include confirming that individuals abide by face covering policies or an assessment of individuals' recent exposures to COVID-19. Employers must also screen employees before each workday and each shift for COVID-19 symptoms. And this could take the form of asking employees to self-monitor for symptoms. If you take this route, you don't have to compensate employees for time spent self-monitoring. OSHA has said that they don't expect employers to pay for the 5 minutes or so that an employee spends at home taking their temperature or self-assessing their symptoms. On the other hand, if you require COVID-19 testing for screening purposes, you must provide such testing at no cost to the employee. The standard also requires employers to notify each employee promptly, or employers must require each employee to notify the employer promptly if the employee is COVID-19 positive, suspected of having COVID-19, or experiencing certain symptoms. The standard also sets out physical distancing and barrier requirements. You must make sure that each employee is separated from all other people by at least 6 feet when indoors, unless you can demonstrate that it's infeasible for a specific activity. So you could think how a barrier of this kind or physical distancing would not be appropriate for hands-on medical care. But if you take this route, the burden is on you, the employer, to demonstrate that it's infeasible to comply with the required physical distancing for a specific activity or workspace. If 6 feet of distance is not possible, make sure the employee remains as far apart as possible from other people. This physical distancing requirement does not apply to momentary exposure while people are in movement, for example, passing in the hallways. Employers must also install cleanable or disposable solid barriers at each fixed work location in non-patient care areas where employees are not separated from other people by at least 6 feet. The barriers must be solid and impermeable, cleanable or disposable, able to block face-to-face pathways between individuals, but may have a pass-through space at the bottom for objects or merchandise so long as that space is not in front of a breathing zone. Other ways to ensure physical distancing include remote work policies, reducing the number of people involved in performing a procedure, if doing so would be safe, posting signs and space markers, and instituting staggered work shifts. Again, it's likely that your company has already instituted similar policies because this standard is being issued so late in the pandemic, but it's worth reviewing the new standard to make sure your current policies do align with these requirements.
Thanks, Claire. I think there's any topic that just by its nature, from people understanding from following the news, knows is subject to change. It's policies regarding vaccinations. Just this week, we've seen the federal government in the form of the Department of Veterans Affairs require its employees to be vaccinated. The state of California and the city of New York have also taken, to varying degrees, measures to require employees to be vaccinated. And we understand that tomorrow, the Biden administration will announce that all federal government employees, to some differing levels, may be required to be vaccinated. And so we expect that the requirements for vaccinations could increase, particularly as there has been guidance from both the Equal Employment Opportunity Commission and the Department of Justice that in general, subject to broad exceptions for religious and health reasons in particular, that there is the authority in this country for certain employers and certain groups to require vaccinations. So more on that to come, but right now we're talking, of course, about this ETS for the healthcare industry, and they do have specific guidance as to dealing with fully vaccinated workers. Fully vaccinated workers are accepted from the standards masking, distancing, and barrier requirements when, and this is important, in well-defined areas where there's no reasonable expectation that any person will be present with suspected or confirmed coronavirus. For example, an employee breakout room where it could be contemplated as off limits to unvaccinated people. Again, this is subject to potential change. There could be increased vaccination rates that make people loosen regulations, makes OSHA decide to loosen regulation whether or not this standard is applied beyond the healthcare industry. Alternatively, with the continued development of variants and increased positive testing, this could be even relaxed further if, for example, vaccination does not prove to be as strong after several months. So please keep in mind in this, with respect to this rule, that it is subject to change. And of course, fully vaccinated generally means 2 weeks or more following the final dose of a COVID-19 vaccine. Obviously for Pfizer and Moderna with 2 doses, that means an elongated process. In order for an employer to be exempt from providing these controls in a well-defined area based on employees' fully vaccinated status, the COVID-19 plan must include policies and procedures to determine employees' vaccination status. Now, there's some more flexibility on this as well. we know that in the United States, there is not a national vaccine passport, nor do we understand that there ever will be under current proposals. And employers are doing different things to verify that status. There could be an attestation from the employee who says they've been vaccinated. There could be other documentation, as long as it's something that can be defended if OSHA comes calling to take a look to see that you actually have done something to make sure that you're identifying those employees who are vaccinated and therefore may be accepted from the standards, masking, distancing, and barrier requirements. And with respect to medical removal protection benefits, this again is an important issue for OSHA in putting forward the ETS. OSHA thought that incentives were very important to put into this plan to get more people vaccinated, but also to have that documentation. Employers must provide workers with reasonable time and paid leave to get vaccinated and recover from any side effects. Many employers, even outside the healthcare industry, have been putting forth their own policies, whether formal or informal, to allow employees to get vaccinated without suffering negative consequences at work, but also to recover. As we know, some people who are vaccinated have, even in a good situation, a day or two of not feeling terrific, maybe exceptionally tired. So there must be, similar to an ADA disability context analysis, a reasonable time and paid leave in that context to get vaccinated and recover from the side effects. This standard for the healthcare industry is not meant to be cost neutral to employers. It's meant to protect employees in this particular sensitive setting. Employers must allow employees who have the coronavirus or who may be contagious to work remotely or otherwise be separated from other workers if possible, or to give the employees PTO of up to $1,400 a week. So again, if an employee has paid time off, that can be used. If they can work, and this is important to OSHA, if they can work remotely without affecting other employees, without being at risk of exposure, whether they're quarantining because they've had exposure or whether they actually have tested positive, there's some standards in here that OSHA is requiring. So essentially, you've got to remove the employee from the work site unless they can work in isolation or remotely. For most businesses with fewer than 500 employees, there are tax credits in the American Rescue Plan that could be reimbursed through these provisions to the extent that an employer incurs these costs from an infected employee. And I would just say that upon return of an employee who has been exposed to COVID or has tested positive, the ETS specifically incorporates by reference the CDC guidance on returning employees. So if you're not familiar with that guidance, it's more generally applicable outside of this setting, but it's also going to be considered in tandem with the medical removal protection benefits that are made available to employees under the CTS.
In certain circumstances, OSHA requires employers to notify employees about potential COVID-19 exposure in the workplace. These notification requirements are not triggered by the presence of a patient with COVID-19 in workplaces where services are normally provided to suspected or confirmed coronavirus patients. So, for example, emergency rooms, urgent care facilities, COVID testing sites, and COVID wards in hospitals. The idea is that your employees are already on notice that they may come into contact with an individual with COVID-19. But outside of those circumstances, if you learn that a person who has been in your workplace is COVID-19 positive, you have certain notification requirements. You must, within 24 hours, notify each employee who was not wearing a respirator or other required PPE and who was in close contact with the COVID-19 positive person. Notification should be by phone, text, email, or in person. You're required to notify all other employees who were not wearing a respirator or other required PPE and who worked in a well-defined portion of the workspace in which the COVID-19 positive person was present during the potential transmission period. So a well-defined portion of the workspace would be, for example, a particular floor. Notification of those employees can be accomplished by phone, text, email, in person, or by posting a message in a common area, for example, on a bulletin board in a break room or a cafeteria or something like that. The notification should specify the date that the COVID-19 positive person was in the workplace. Additionally, employers have an obligation to notify any other employers whose employees were not wearing a respirator or other required PPE and who were in close contact with or who worked in the same well-defined portion of the workspace as the COVID-19 positive person during the potential transmission period. The notification must specify the date that the COVID-19 positive person was in the workspace and their location. OSHA defines close contact to mean within 6 feet of the person for a cumulative total of 15 minutes or more over a 24-hour period during the potential transmission period. What does potential transmission period mean? That period runs from 2 days before the person felt sick, or if they were not showing symptoms, 2 days before testing, and then continues until the person enters isolation. Of course, you should not include the COVID-19 positive person's name, contact information, or occupation in the notification. This is about letting people know that there's been a potential exposure, not about letting them know who potentially exposed them. The new standard also imposes certain record-keeping requirements. Employers with more than 10 employees must establish a COVID-19 log of all instances in which an employee tests COVID-19 positive. Importantly, this is without regard to occupational exposure and even if the employee is asymptomatic. Employers must record the case on the COVID-19 log within 24 hours of learning that an employee has a confirmed COVID-19 positive test or has been diagnosed with COVID-19 by a licensed healthcare provider. The COVID-19 log must be maintained as though it is a confidential medical record, and employers must update the COVID-19 log as long as the standard remains in effect. You're not required to record instances for employees who work exclusively from home, the idea being that they could not expose others in the workplace. And importantly, the size exemption for employers with 10 or fewer employees is based on the total number of employees in the firm, rather than the number of employees at a particular location or establishment. The count should include all full-time, part-time, temporary, and seasonal employees. There are also certain requirements for making the COVID-19 log available to employees. Employees must make the COVID-19 log available to employees, employee representatives, and OSHA representatives upon request by the end of the next business day after the request. And there are different requirements about what employers must provide based on who's doing the asking. So for an employee listed on the log or anyone to whom the employee gives written consent, the employer must provide a copy of the individual COVID-19 log entry. To any employees, their personal representatives or authorized representatives, the employer must provide a version of the COVID-19 log that removes the name of employees, contact info, and occupation, and only includes for each employee in the log, the location where the employee worked, the last day that the employee was in the workspace before removal, the date that the employee's positive test or diagnosis occurred, and the date that the employee first had one or more COVID-19 symptoms. And then for OSHA representatives, employers must be prepared to share all information entered on the COVID-19 log. The new standard also includes reporting requirements. Employers must report work-related COVID-19 fatalities to OSHA within 8 hours of employer knowledge, and must report work-related COVID-19 inpatient hospitalizations to OSHA within 24 hours of employer knowledge. And this reporting requirement applies regardless of the amount of time between the COVID-19 exposure in the workplace and the death or inpatient hospitalization. But note that if you report an inpatient hospitalization and the employee subsequently dies from the illness, the employer does not need to make an additional fatality report to OSHA. So the first report is sufficient. You can report a fatality or inpatient hospitalization subject to this rule by calling the nearest OSHA office, calling the OSHA 24-hour toll-free number, or by submitting an OSHA serious event reporting form, which would be available online.
Thanks, Claire. And my takeaway on a lot of these record-keeping requirements, a couple things. One is they preserve confidentiality. And it's a reminder that this new standard from OSHA does not supersede other requirements except as specifically stated as to workers' compensation, the ADA, and other issues that particularly those who are working in an HR function are aware of, that there's overlapping laws, sometimes with contradictory purposes that all must be considered. This standard and the materials we were covering today is obviously not a license, even in a pandemic, to throw out the requirements and regulations that are contained in these other laws. As to whether there's a conflict, we can encourage you to consult with counsel, obviously, to determine the best way forward. As to determining if an employee contracted COVID-19 at work, in some cases it may be obvious, in some cases it may be a closer call, in some cases it may be easy to say, no, it just did not happen. There's specific criteria that is laid out in 29 Code of Federal Regulations, section 1904.5. You or your counsel can review those. I'm not going to go over all of them. They're listed out there. But I think the key words, the key phrases in this standard for determining if an employee has contracted this illness at work is that it's either caused or the work environment either caused or contributed to the resulting condition. And what does contributed to? What's the level? Is it a preponderance standard? Is it mostly contributed? It's subject to some interpretation. But if the COVID-19 exposure likely occurred within the employee's work environment, the reporting of a subsequent inpatient hospitalization, or in the worst case scenario, a fatality, is going to be required. So for example, to consider among the factors in determining if the employee actually was unfortunately exposed and contracted COVID-19 at work, there are different factors that will come into play as laid out in the regulation. The type, extent, and duration of contact the employee had at the work environment with others, particularly the general public. In a healthcare setting, there obviously can be people who work up front who may come into contact with patients and their family members. There may be people who are more isolated, and it's clearly identified as to who they interacted with. So your particular situation, the employee work site, is going to really matter, but consider obviously the exposure with the general public, in which case they may have interacted with more people. Physical distancing, another factor to consider. Other controls that impact the likelihood of work-related exposure. If someone tests positive and is subject to this reporting requirements, there needs to be an inquiry as to the likelihood that this is a work-related exposure, and not just assume it. The extent and duration of the time spent in a shared indoor space, particularly with limited ventilation. Hopefully your workplace hazard assessment has covered that, and you can refer to that and then assess the particular employee affected and his or her time spent in a shared indoor space. Many offices, to the extent possible, particularly in a healthcare setting, require doors, masking, and other protection. All that should be considered. And then, of course, whether the employee had work-related contact with anyone who showed signs and symptoms of COVID-19. Obviously, that will be critical if there's obviously other symptomatic people. Takeaway from this is that either caused or contributed to will want to make a person probably make sure they've documented what they've done to see if it's work-related, report if necessary, and of course, keeping in mind the confidentiality requirements that are appropriate and usually covered by other laws. All of this is going to be possible if you train your employees to be able to cover this. And let me actually give one example as to when you might train an employee for determining if the employee contracted COVID-19 at work. If they're on vacation, for example, for a long period of time, they clearly got it there. In that situation, you may reasonably conclude perhaps they didn't contract it at work. With respect to training, obviously, as you can expect, anytime OSHA puts out a standard, they're not just going to expect to have a brand new shiny plan that you can point to, but that actually people are aware of it and that your policies are being carried out by your employees. So with respect to documentation, it's critical to make sure that your efforts to create a safe environment for your affected workforce is documented. So employees must be trained on workplace policies and procedures regarding the COVID-19 plan. It's got to be in a language that they can understand. Although we're lawyers, we also understand that especially realize that merely putting out legal requirements is not always helpful for the workforce. They've got to understand how it affects them. To date, as I understand it, there is not an OSHA poster that you see in other contexts by other agencies, including OSHA, though, that must be posted where employees are likely to congregate. And of course, that could be subject to change. But make sure you're using language that employees can reasonably understand. And otherwise, if they are confused by it or it's overly complicated, if something may run awry and you'll violate the standard. The training must ensure that the employees understand disease transmission, the tasks and situations in the workplace that could result in a COVID-19 infection, and then the relevant policies and procedure. Importantly, this standard is being put out 18 months into a pandemic. We've had ups and downs, and a lot of work sites have reopened. A lot of, obviously, healthcare settings have been required to stay open. And of course, they have taken measures, as critical as they are to the health and safety of our populace and our workers, to keep their work environment safe. And they've had training, and there's been other guidance from the CDC and even OSHA as to how to go about that training. This is relatively lately issued. And so the OSHA recognizes that there is training that has already been done. And so that there is no expectation of retraining created by this ETS, with some important exceptions. For example, retraining must occur if there are changes that affect the employee's risk of infection. If there are policies or procedures that are changed, for instance, in response to this webinar or the ETS more specifically, that hopefully enhance or increase protections for employees, you've got to build off that training and have retraining that shows it. Or retraining where there's an indication that an employee has not retained all of the relevant understanding or skill. Obviously, if you have a great training session, but it's just not sinking into an employee, or for whatever reason, an employee is not following this, there could be an expectation of retraining despite you being able to point to training that may have been sufficient in other contexts. Note that employers may rely on training completed prior to the effective date of the ETS, just to the extent that it meets the relevant training requirements. So I'm not telling you that if you've done training on limiting COVID exposure or dealing with affected employees, you're covered, you're sufficient. No, this ETS must be reviewed very closely to make sure that training is covered. And of course, other than potentially burdening your employees, though, to the extent you feel that it may not have sunk in or may not have been covered, we encourage you to retrain. And again, if you're going to rely on earlier training that may have occurred even as far back as 2020, which again, OSHA may take a dim view of because circumstances change, guidance change. But if you're going to rely on any type of earlier training prior to the effective date of the ETS, you've got to document, and again, that's late June 21st, I believe. You've got to document of this year. You've got to document how you concluded that prior training was sufficient to meet the goals and objectives and requirements of the ETS. And then you've got to document how you trained employees on missing elements from the prior training that are now required, if any. We hope that maybe you look at this ETS and realize that you've been following these pretty closely. And if so, it's required that you document that you've made that determination and why you made that determination. I talked earlier about the concept of this not being cost neutral to employers, and there being incentives for getting people vaccinated, and having employers make sure that they're not implementing measures that impact employees in a negative way with respect to compensation or otherwise if they're going out to get vaccinated. Well, it probably doesn't come as a surprise to people who are interested in this standard to know that OSHA is also concerned, as they are more generally in workplace safety, with making sure that there are anti-retaliation provisions in place and that there are no costs to the employees. So employees must be informed of their rights to the protections required by the CTS, and they must be informed that they will not be discharged in any manner that discriminates against employees for exercising those rights or engaging in actions required by the standard. You want your employees to know in the covered settings that you are focused on this ETS and you're trying to comply with all the necessary requirements, and that they won't be discriminated against if they raise a concern about that. Again, there's flexibility in this in terms of how to inform employees of their rights and of the prohibition on retaliation. It's not as easy as just putting up one poster. You've got to have the training, you've got to have the notifications, you've got to have this all documented. You can provide the information on the ETS, even with respect to no cost and anti-retaliation for employees who are working with this, in connection with other training that you may be doing under this standard, or you can provide it separately. Just make sure you document it. If you're going to have training on the ETS for staff and there's no mention of the anti-retaliation provision, you want to be able to point, for example, to a separate communication that got out that information. You can inform the employees in writing, verbally during a staff meeting. Again, documentation may be an issue there, but you may be able to accomplish that, or other methods. But just as long as each employee is reasonably apprised of the information in the new standards. The ETS does not change the obligations of employers to refrain from retaliating against employees for engaging in protected activity. And I'm not talking, of course, about under the Department of Labor regulations, though those are there as well, and you should be aware of them, but also under Section 11C of the Occupational Safety and Health Act. So this is not a superseding anti-retaliation measure. It's an additional requirement that must be communicated to employees. And again, the purpose of the anti-retaliation provisions is to increase awareness of these protections that are provided to employees and to provide OSHA with an enhanced enforcement tool to protect employees from retaliation. So this is going to lead potentially to more lawsuits, not fewer, particularly if these anti-retaliation provisions are not being followed, but also communicated. And again, this must be at no cost to the employees in terms of employers coming into compliance with these requirements. This is a burden on employers. This is not a burden on the employees, although they are expected to reasonably participate with the employer who is cooperating in good faith. OSHA is going to consider costs to the employees that are prohibited to not just being direct monetary expenses to the employee who may have done something to try to get into compliance with this, but also time and other expenses necessary to perform required tasks. This is part of their job duties that you're required to adhere to, and this must be at no cost to the employees.
And DJ, just to follow up on that, this seems an area where there could be a lot of nuance and where you would want to consult legal counsel if you're trying to understand whether a certain step that you're taking to comply with the standard does impose any kind of cost to employees. So encourage you to reach out to us or other legal counsel to make sure that what you're doing is appropriate under the standard. And that brings us pretty much to the end of our presentation. I put up here some sources. There are many, many sources out there, including on OSHA's website. These are the ones we chiefly relied on. Everything here is subject to update and interpretation, as DJ mentioned at the top. So please do reach out to us if you have any questions. And I believe that these slides will be made available to you after the presentation.
Thank you, Claire. Let me just reiterate the need to focus specifically on your workforce. This is not a cookie cutter approach. The guidance is not gone through years of litigation. Unlike a lot of other guidance that was issued in March and April, when we had employers calling us, trying to react in real time to what was going on in their work sites with shutdown orders, with reopenings, with varying degrees of who is a covered employee, who's a essential employee, and the guidance not being very clear. This is a situation in which OSHA has thought very carefully. Again, it was rumored, there was rules out there that seemed to indicate that this could have applied more broadly, and it was limited, as Claire said, to the healthcare setting. So I think that the healthcare setting is going to be ground zero for determining whether or not these regulations actually work. We had all hoped, obviously, by July 4th to be done with the pandemic. We're nowhere close to being done, it appears, and so these regulations are going to take form. As more and more employees come back to the work site, and there's debates about vaccination status, especially if there's increased hospitalization, these rules are becoming more and more important. So we encourage you to watch out for updates, consult with your counsel if possible. We do have a question from one of our participants who's asking, in the home care business, she's unclear as to how to do a hazard assessment as they are in so many different homes. And so that maybe there would be a separate call. Again, and I'd like Claire to weigh in on this, but I think that's exactly the type of flexibility that OSHA is recognizing is required, because even within healthcare setting that is not exempted from these rules, you're going to have different ways in which people congregate, different types of patients, different types of interactions with the public and others. And you're going to have multiple sites. So you have one business, for example, maybe an adult care home or a home care business, home health care. There could be situations in which it would be very, very necessary to have a fact-intensive evaluation. And Claire, I'd like you to opine on this, but I would think that you would certainly be required from OSHA to show that you looked at all the different facilities that are covered and not just applied one size fits all, unless, of course, the situation is reasonably the same and you document that this standard, this plan that you've come up with, this hazard assessment that you've done is generally applicable.
I think that's right, DJ. And then I'll direct the individual also to the OSHA website, and they have posted on there many, many useful resources, including a healthcare worksite checklist and an employee job hazard analysis form. So look through that and see if it provides any guidance, but it does also seem like a situation where you'll need to consult with legal counsel about your particular circumstances.
And as stated in the chat, we will be making this video presentation available on our website. It usually comes out the day after our presentation. And these slides will also be emailed to you as well. We've endeavored, particularly Claire, in putting this together, to have in there not just photographs that are good for us to talk through, but actually good information that you can use, not a substitute for legal advice, but informational purposes, and that you can use to make your decisions regarding your own healthcare setting. If there are no more questions, we greatly appreciate the opportunity to be with you and present to you again